Our last panelist is John Morone. I'm very pleased to introduce him. John is a partner in Fryer Levitt. He joined in 2008. He brings 20 years of healthcare experience, holding positions with academic medical centers, private and publicly traded physician practice companies, and healthcare consulting groups. John received his JD from Seton Hall. He also is one of those useful crossover types that has an MBA as well in hospital and healthcare administration. He is a partner in the healthcare department with a focus on transactional and regulatory law. John spends a lot of his time dealing with all the issues that really keep us up at night and assisting clients with pharmacy services, HIPAA planning, OIG, and all of the rest that, like I said, frighten us and keep us awake at night. So John is here to talk about ancillary provider relationship strategies. Thank you.
Good afternoon, everybody, and thank everybody at National Spine and Pain for inviting me to speak here. As I was listening to the sessions earlier today, all the way up to the one that just occurred, it dawned on me that this should not be called ancillary services. It should be called integrated services. And my partner, Dan Fry, will be speaking about integration of practices tomorrow. But what we're really talking about here, and if you really want to think about it, is that it's integrating these other services, laboratory, imaging, chronic care management, a variety of other clinical areas that are really integral to the delivery of pain management. So some of the objectives that we want to get is today, and I'm going to be covering a lot of material very quickly, and it's very complex material. It's a 3-credit class in law school just on Stark and Anti-Kickback. I'm going to do my best to give you the highlights so that you can recognize some of the pitfalls, but also recognize the areas where there's opportunity and how to exploit those opportunities for the benefit of your patients, and because this is the business of pain, how to enhance the revenue streams to your practice. So here are some of the ancillary opportunities. A clinical laboratory, which we just heard about, imaging services, ambulatory surgery centers, which I'm sure many of you already know about, may already have ownership in or be affiliated with, physician-owned pharmacies, physician dispensing of medication in office, telehealth services, which is an emerging area that that you can participate in, and with creative thinking, use telehealth to reach out to those primary care physicians, to reach out to patients in geographically distant areas, to get professional pain management to patients that are not being managed correctly now because they either don't have access to specialists or the folks that are treating them are not well versed in pain management. Chronic care management, one of the disciplines within CMS that has emerged in the past 2 years, managing patients remotely. CCM is something that it's a 20-minute a month non-face-to-face encounter that's reimbursable by Medicare, that Medicare is advocating be used, okay, and then others, clinically integrated networks and ACOs. Where are the opportunities? To increase fee-for-service revenue. That's kind of always the mantra that you hear all the time. But in the emerging areas of reimbursement, with the advent of MACRA and MIPS on the CMS side, it also provides opportunities to deliver better care, collect more data, be able to report outcomes and report quality metrics that will result in greater reimbursement on the fee-for-service side, okay? It improves patient care by pulling these things within your practice, such as laboratory, telehealth, that pharmacy. One of the areas that we at our firm have had a lot of experience with recently in a group of our attorneys have written a white paper that's going to Congress about physician dispensing that was written interdisciplinarily with physicians, is that the outcomes when physicians dispense medication in their office are better than when pharmacies do it, particularly the big chain mail order pharmacies, because the metrics like time to fill and fill rates are better when the physician and the clinical staff is delivering medication face-to-face to the patient. Also, when you integrate, it streamlines the referral process, reduces administrative overhead, and ultimately it puts you in a better position to negotiate with payers. You can negotiate episodes of care, which is another area of reimbursement that is an emerging trend. So now let's talk for a moment about what everybody hears about, anti-kickback. So some of the challenges with integrating other areas within a medical practice is the Federal Anti-Kickback statute. Okay? So the Federal Anti-Kickback statute is written extremely broadly, and it's probably the reason that it creates so many problems for so many people to understand. Basically, the way that it's read is that any arrangement where the referring physician or the referring party gets remuneration for that referral is violating anti-kickback. So the Congress wrote this very broadly and then created a bunch of safe harbors, which I'll talk about in a few minutes. But fundamentally, there are ways to structure transactions so that you don't run afoul of the anti-kickback statute. Stark and anti-kickback often get confused, or people just kind of pronounce them in the same way. Anti-kickback is paying for a referral, direct remuneration for a referral. Stark is the physician's self-dealing statute, which means a physician is making a referral to an entity that they have an ownership interest in. So anti-kickback refers to anybody. Stark is a physician's self-referral. We also have to worry about when we do any transaction, whenever we're structuring an arrangement, there's a variety of state laws that we have to be concerned about. There's state anti-kickback statutes, there's state what's called mini-Stark laws, there's insurance fraud protection laws, professional board, rules and regulations that we have to look at. Department of Health, if you're involved with ASCs or other licensed facilities. And then there's certain federal preemptions to state law that we have to be concerned about. So there's this whole matrix of laws and regulations that we have to deal with. Okay? Now, one of the areas I want to talk about, which some of you may have been faced with, and that's something called an MSO, or Management Service Organization. Now, there are a number of different definitions of MSOs, some good, some bad. We're going to talk about the bad one for a few minutes, because you will probably at some time in your career be faced with one of these. Very frequently, what outside groups will do is that they will create a structure, present to you this structure along with a bunch of legal documents and said, oh, this is perfectly okay. It's been thoroughly vetted by healthcare counsel, and you don't have to worry about anything. And it involves a situation where physicians buy into this MSO. The MSO enters into contracts with various ancillary providers like laboratories, imaging centers, pharmacies. Those ancillary providers pay the MSO a percentage of their gross revenue, and the physicians, as a member of the MSO, receives a profit distribution. Okay? That is very problematic, and many folks have unfortunately gotten into trouble with the federal government because of these types of arrangements. Fundamentally, the takeaway from this is what you can't do directly, you can't do indirectly. You can't put a bunch of entities in between you and a provider and violate Stark or anti-kickback and feel that you're immunized because you put an entity in between. So how do we go about developing ancillary services in a regulatorily compliant way so that you can serve your patients, deliver good care, increase the size of your practice, increase your profitability? Well, this is perhaps one of the most difficult things in law to explain. So let me put it this way. And when I lecture to law students, this is the way that I try and explain it. Congress wrote this law that's very all-encompassing, that you can interpret so many activities as being illegal. And then they decided, well, what we're going to do is we're going to create another bunch of laws that says, you know what, if you receive money for a referral, it's illegal, it's a crime. But if you do it the way that we describe here, we don't consider it a crime. So think about the most simple example of a safe harbor is the speed limit is 65 miles an hour. If you go 70, you're breaking the law. But if you go 70 in a police car with the lights and sirens on, you're not breaking the law. And that's how safe harbors work. If you meet all the elements of a regulatory safe harbor, then the government doesn't consider it breaking the law. So the best example of this is the ambulatory surgery center safe harbor. Clearly, without a doubt, if you look at it outside of the safe harbor, a physician owns an ambulatory surgery center or has an ownership interest in an ambulatory surgery center, refers their patient to that ambulatory surgery center, and gets profits from that ambulatory surgery center. Those profits are derived from the referrals that they're making to that ambulatory surgery center. So how is that not a kickback? Because there is a safe harbor that speaks to ownership of an ambulatory surgery center. And if you meet all of those elements, you are in the safe harbor. So there's a variety of other ones: rental of office space, employment arrangements, personal services safe harbor, management contract safe harbor. So you know the bad MSO that I talked about before, there is a way to structure management service agreements. There is actually a safe harbor called the personal services and management contract safe harbor. If you meet the elements of that safe harbor, you're safe and your arrangement will be protected. Some of the pitfalls of these ancillary arrangements, and the speaker prior to me demonstrated some of those, is that unfortunately as physicians you're put in this conflicted arena. On the one hand, you're doing things that benefit patients and also making additional revenue. And your board, your professional board says, we want you to test patients on opiates every 30 days. And then you have CMS or the private insurers on the other side saying, you're overutilizing these services, okay? So how do we avoid that? Well, number one, the best way is if we're doing things that benefit the patient, if we have good practices, we have good standard operating procedures, and they're followed, and there's integrity in the process, that is one of the best defenses to any accusation of overutilization, all right? One of the other pitfalls is partnering with bad actors, okay? When people come to you with kind of the old adage, if it sounds too good to be true, it is. Any agreement, anybody that comes to you with agreement, it really needs to be vetted by a qualified healthcare attorney. Some of the benefits, again, improved coordination of care. When you have everything in-house, you have greater access to patients. You have greater access to those services. One of the examples of something that we're working on that combines telehealth and some of the guidelines on mental health counseling is actually putting telehealth services in the pain management practice, where the patient is getting mental health counseling via telehealth right in the pain management practice. You get improved patient compliance. As I mentioned earlier, the fill rate for prescriptions is demonstrated to be higher when physicians dispense than when you send patients out the door with a prescription. Or, again, like the other speaker talked about New York, which is where I come from, if you can't tell by my accent, is New York now mandates everything be e-prescribed. So now patients aren't even walking into the pharmacy with a prescription. All right? Physician is sending it electronically, so you really don't know if the patient's being compliant or not. Whether they understand what's going on with the medication. You're relying on the patient to go to the pharmacy, or even worse, relying on the patient to call the pharmacy or go to the pharmacy, and that pharmacy ships the medication to the patient, and that patient actually picks it up and actually takes it. Any questions? Yes.
How could the doctors involved in biodiagnostic labs get more trouble?
Okay, so the question was about the biodiagnostic scandal. And I think as of right now, 30-something physicians have gone to jail. Dan and I, my partner Dan Fryer and I, were involved in this 7 years ago. And we actually lost a lot of physician clients because they came to us with this and we told them they couldn't do it. And they did something that I refer to as citing to ubiquity, which meant it must be okay because everybody's doing it. And in biodiagnostics, the typical scheme was the lab would pay physicians $1,000 a month to rent space in their office for a draw station, but the physicians were only paying $1,500 a month for the entire space. And it didn't meet, there's a space rental safe harbor. It didn't meet that safe harbor, and it was a disguised kickback, and people have been prosecuted for it. Yes?
Could you elaborate on the arrangement with MRI, for example, when the patient can rent an MRI, and I've seen groups working that way, renting instead of owning shareholders.
Yeah. It's a Stark issue. It's not really legitimate. One of the things that people do is really important for you to be careful with is that people will often believe that if you don't bill federal health care programs, that you can get away from the federal laws, and that's not true. There is one, the federal government is taking the position that carving out federal health care programs does not sanitize, and number two, people forget that there is a federal criminal statute called the Health Care Fraud Law that applies to payments for health care services, irrespective of whether it's a government payer or a private payer. So those particular arrangements are dubious at best. Yes?
Can we work in coordination with the psychologist, clinical psychologist on higher clinical psychologist, provide the counseling and stuff?
Within your practice? Yeah. That is essentially a state law issue, and whether within your state, what disciplines can be within one practice. Some states require yeah, they all have to be physicians. Others allow physicians to hire, if it's a physician group practice, some states allow other clinical disciplines to be within that practice. So it would depend on state law.
I think we might have talked about this briefly, but you know, I've been approached by MSO models and physician investment models, and it sounds like what you're saying is almost the same.
Yep.
They pool a bunch of physicians that have similar volume. We have a brick and mortar lab, which you send your commercial to. And does that kind of arrangement comply with Stark and AntiKickback law?
It's difficult me to opine exactly on a particular arrangement. But generally, those types of arrangements where there's multiple physicians that are in multiple groups or billing under multiple tax ID numbers, having an ownership interest in an ancillary provider and receiving a benefit from that, generally those are not appropriate transactions.
Last year you talked about this arrangement of the out-of-network surgical centers and physicians that were in-network with a particular insurance contract, and then taking patients with out-of-network surgical centers.
Correct.
That they had ownership in, and there was, I think you mentioned some type of lawsuits with stigma involved with some of these surgical centers. I was just wondering if you comment more on that.
Honestly, I have not. I don't know the outcome. I mean, that's something that we'll find out before the end of the. Maybe Dan, do you know if the outcome of the Cigna out-of-network lawsuit? Yeah, we'll find that out for you. Honestly, I did. You know, what this gentleman was referring to is that last year one of the areas that I presented on was situations where the physician practice is in network, and those physicians or some of the physicians have an ownership interest in an ambulatory surgery center that's out of network, and they refer cases there and do the case, bill the professional fee in network, but the ambulatory surgery center is receiving out of network payments. And in New Jersey, one of the insurance companies filed a lawsuit against that practice.